Good morning, everyone. Good morning. I'm so glad to have so many people here in the audience in person. And very good morning to all of you attending with us virtually. I'd like to welcome you to our 4th annual DEI Symposium, the intersection of health and equity. But before I introduce our wonderful keynote speaker and Grand Round speaker to our symposium, I'd like to take a moment to honor the recipient of our 2nd annual JEDI Award. The Department of Pediatrics is committed to leadership in pediatric healthcare, education, and discovery. Diversity, equity, and inclusion are essential to our mission of creating an environment in which all faculty, staff, and trainees are valued in an environment which all can succeed, and they are empowered to thrive, to reach out to our patients and our families to support their goals. The JEDI Award is to recognize a member of our department in the pediatric faculty who is a champion for justice, equity, diversity, and inclusion. You get it, JEDI, right? And that person practices inclusion in pediatric medicine, as well as being very involved in our community. And I am very thrilled to announce this year's recipient of our JEDI Award is Dr. Andy McCormick. Andy. And now that I have you up here, just to embarrass you, I didn't tell him this part, I am going to share with you the nomination that got you this award, okay? And let everybody know about our amazing Dr. McCormick. So, as his nominee wrote, diversity, equity, inclusion lie at the core of nearly every endeavor that Dr. McCormick undertakes. He has developed several curricula to enhance education around DEI topics, including at the medical school and right here at Children's of Pittsburgh. Much of his work has been contributed to his receiving the Social Justice Education Award from the University of Pittsburgh School of Medicine in 2022. He has been asked to serve as a consultant in the development of these curricula for other groups, including adapting IDEA Rounds, which stands for Inclusion, Diversity, Equity, and Awareness, for other divisions within the Department of Pediatrics. The success of some of these curricula has led to the publications and award-winning presentations locally, regionally, and nationally. This unquestionably enhances the DEI education for innumerable providers and trainees around the world. Congratulations to Dr. McCormick. And so now, I am so very, very happy to have you all here in person and you out in the virtual space. And I would like to introduce our tremendous keynote speaker. And following that, we will be having our faculty and staff and folks here who are working in the health equity space, doing research and programming in our hospital. So let me first now introduce Dr. Ray Bignall. Dr. Bignall is the Chief Diversity and Health Equity Officer at Nationwide Children's Hospital in Columbus, Ohio. He also serves as Director of Kidney Health Advocacy and Community Engagement for the Division of Nephrology and Hypertension, and he is the Associate Professor of Pediatrics at The Ohio State University College of Medicine. A graduate of Howard University and Meharry Medical College, Dr. Bignall went on to do what we like to call around here the trifecta of being trained and completing his general pediatric residency, clinical fellowship in nephrology, and NIH postdoctoral research fellowship at Cincinnati, also known to us as Cincy. As a physician advocate, Dr. Bignall works addresses social determinants of kidney, child, and community health through community-based scholarship, engagement, and advocacy. He has served as a member of the White House Health Equity Roundtable and Access to Care, serves as the inaugural chair of the American Society of Nephrology Healthcare Justice Committee, and is a member of the College of Medical Legislation for the National Medical Association. Dr. Bignall is recipient of the American Academy of Pediatrics Access to Child Health, also known as the CATCH Award, and John E. Louis Fund Advocacy Scholar for the American Society of Pediatric Nephrology. And he was named 40 Under 40 leader in the Minority Health by National Minority Quality Forum and the Congressional Black Caucus Health Brain Trust. Please put your hands together and welcome with me Dr. Ray Bignall.
Right. Well, thank you so much. Good morning, everybody. It is good to see everybody here. It's good to have seen some friends this morning, including my buddy from residency, Dr. Al-Sayed. You know, we're getting old now, I guess, is what I'm gathering. You know, when you start seeing your buddies from residency and they are well heeled in their second faculty appointment and doing big things. But we are I'm incredibly grateful to be here and incredibly thrilled to have spent so much time with all of you. I want to talk to you guys today about what Kids and Kidneys can teach us about racism and health equity here in Pittsburgh. And just, you know, it wouldn't be an academic talk without an objective slide, right? So we got to go through our objectives today. We're going to define race and racism as social constructs and sort of overview their historical context in the United States. We're going to briefly highlight a few of the racial and ethnic health disparities that we see in pediatric kidney care, the objective of which is to link them to the structurally racist and unjust systems that perpetuate these disparities, and then discuss our role in changing, the sort of changing anti-racism and health equity landscape and what we can do to help promote health equity. I have no relevant financial relationships to disclose, but I'm always looking for some. So if there is anybody here who's got a good side hustle for your boy, let me know. Let me know. I would be thrilled to be involved in that. There's another important disclosure for us. I pulled this off of the website for your state, Commonwealth, your Commonwealth voter registration information. Who here is registered to vote? There we go. I love to see the hands, the rush of wind that I just felt with all the hands being raised, people being registered to vote. Somebody told me this is a very important election. So I included the deadlines for you down there. I like to vote early and in person. I like to vote in person because I like the sticker. You know, I like to get the little sticker. And but you know, if you want to, if you enjoy thrills, if you're a thrill seeker, and you want to vote on election day, that's November 5th for those of you keeping track at home. So put it in your planner, put it in your phone, and be sure to exercise your franchise. People died so that you had the right to exercise this most precious gift in this, the greatest country in the world. All right. So let's talk a little bit about equity. So I got a question for you. Who cares about equity? All right, really? Who cares? I'm glad you do. I'm glad you do. But you know, there are some people who don't. Actually, right now, we are living in a cultural moment where there is a tremendous backlash to the concept of equity. In fact, DEI is now sort of a shorthand slur. I would say it's a four-letter word, but one of those letters is left out. So it's used as an insult, a pejorative, to brand things as unworthy in society. Who cares, therefore, about equity? Well, I'll tell you a quick story. This is the first photograph that I ever had of my son, Liam. Now, you don't have to be a radiologist or skilled in POCUS to know that this is a remarkably cute baby. I mean, you can look at that forehead right there. This is a beautiful, beautiful kid. My son, Liam, has already interfaced with our healthcare system at Nationwide Children's Hospital in a variety of different ways. And when my son engages with our healthcare system at NCH, I may be the chief diversity and health equity officer at one of the 10 best children's hospitals in America. one of the largest children's hospitals in the United States. But I can do nothing to ensure that my son has an equitable outcome. I am entirely reliant on my colleagues, doctors, nurses, therapists, administrators, caring about my son's equitable outcome as much as I do. This is why I care about equity. My son is doing great now. He's thrilled with bubbles. Bubbles are his big thing. I'm even teaching him a little bit about nephrology. You know, we want to train him up. You know, we want to train him up early so that he can be a successful nephrologist. He can do whatever he wants to. I want my son to be whatever, any kind of nephrologist he wants to be. Whatever he wants to be in life. So this is the reminder that I want to share with you, okay? For my family, as is the case for all families, every single family that you see, regardless of their race or background, regardless of what language they speak at home, regardless of where they come from, health equity is personal. Health equity is personal. So the question should not be, who cares about equity? The question really should be, do you care about equity? Now, you all are brilliant trainees at the University of Pittsburgh. And I know some people who've come through Pitt, and they're all fancy, smart, brilliant young folks. So there's a reason you guys were ahead of the curve. You jumped on the answer to this question. But my charge to you is that you will inspire others to want to have the same answer to this question that you have. Why is this important? Well, it's important because it's been over 4 years since the overwhelming outpouring of support that we saw during the movement for Black Lives. Do you all remember that? Do you all remember that? It seems like a distant memory now, doesn't it? What has been its legacy? What has been the legacy of the movement that we all witnessed and some of us were a part of? Well, we've seen new legislation to disenfranchise Black and brown voters at the ballot box. We have seen an increase in negative sentiment towards indigenous communities in our country. We've seen an increase in anti-immigrant violence, an increase in violence against our Asian and Pacific American neighbors, Jewish, Muslim, Sikh Americans. We've seen in this very community one of the worst attacks, anti-Semitic attacks in our country's history, right here, affecting this wonderful Yinzer community here in Western PA. We've seen legislation that is specifically targeting LGBTQ youth and their healthcare providers introduced in states from coast to coast. And of course, we've seen Supreme Court decisions that have systematically devalued and dismantled fragile efforts to promote equity and justice in healthcare and society. So we are reminded that the marches of 2020 did not somehow suggest the end of our work, but rather they were the beginning of our work on a long road to justice for lives that matter. As this quote that I love, attributed to founding father and fellow Commonwealth native Benjamin Franklin says, "Justice will not be served until those who are unaffected are as outraged as those who are." Anywhere you see injustice against any community should be outrageous to you and to me. To understand the tree of injustice, and the fruit, by the way, that it's bearing in society today, we must examine its roots. And at the root of injustice, we will invariably find racism, which is, in fact, one of the oldest forms of injustice that has been a part of our nation's history since its founding. Race and racism impact nearly every aspect of American life. This isn't a controversial statement. We all know this to be the case. If you just live life, you know that these are things that we think about on a daily basis. And at its core, racism works in tandem with systems of inequality that permeate all aspects of our society. You know, if we had all day together, I would need maybe a comfortable chair instead of standing behind a podium, and we could talk about the way that food insecurity, residential segregation, education, housing and shelter, environmental justice, income inequality, policing practices, and health inequities all intersect with systems of inequality. We won't do that today, I promise. I won't keep you here too long. We'll just focus on three of these that I think are critical to our understanding of inequality and what we can do about it. And we'll start with residential segregation, the history of which is brilliantly outlined by Richard Rothstein in his 2017 bestseller, The Color of Law. Have any of you read this book? This is a fantastic book. It's really depressing, but it's a fantastic book. I would encourage you to read it. This is the history curriculum that many of us did not get in high school history class. The Color of Law is a fabulous read. And by the way, if you, like me, believe that audiobooks are totally reading, okay, then you should consider the audiobook as well. Residential segregation represents the single greatest driver of inequality that we see in American society today, here in the 21st century. Central to this understanding is the debunking of a myth, which we must do today. The myth of so-called de facto segregation, this idea that somehow communities self-segregate. You've heard this before. I know I've heard this before as well. When in fact, much of what we see with regards to segregated communities, the foundation of this was laid intentionally by those in power to determine who lived where. And we'll talk a little bit about how we know this to be the case. As the federal government was seeking to bring Americans out of the mass poverty of the Great Depression, the ambitious, and I like to remind people, politically liberal, okay, policy agenda of Franklin Delano Roosevelt's New Deal was designed to help subsidize Americans' home ownership as a way of undergirding the growing middle class with wealth and an economic floor. Brilliant idea. In theory, we want to give everyday Americans insulation against the kind of mass poverty that they had just experienced in the Great Depression. And still today, we all recognize this in this country. Home ownership represents the greatest opportunity for wealth transfer between families, correct? This is often the greatest asset, the most valuable asset in most families. And such an asset helps to insulate families from financial stress, like the kind that might be incurred by unexplained expenses, like medical expenses, for example. Many of our patients and families deal with this. The federal government provided these lifeline programs to millions of Americans, and they did great work for those Americans. Oh, except that Black Americans were explicitly excluded from participating in these programs, despite the fact that their Black tax dollars were contributing to the system that helped to subsidize homeownership for their white neighbors, okay? With devastatingly surgical precision, the Homeowners Loan Corporation, an aspect of the federal government, program of the federal government, used color-coded maps to indicate which neighborhoods were worthy of federal investment and which neighborhoods were not. In a moment, we will take a look at some of these maps and understand how far-reaching the consequences. The Digital Scholarship Lab, any of you guys like to fall down Wikipedia wormholes? I don't know if you do. I love Wikipedia wormholes. I love maps. I love this stuff. If any of you love this, you should check out the Digital Scholarship Lab at the University of Richmond. This is where I got all of this data from. The Digital Scholarship Lab at the University of Richmond. They have a project called Mapping Inequality. They have redline maps from across the United States. I like to remind folks that some of the most historically segregated communities were not in the South. In fact, most of the most significantly segregated communities have been in the Midwest. I don't know, do Yinzers think of themselves as Midwesterners? No? because you guys are Midwesterners. You really are. I know you think you're better than us, but you're really Midwesterners, all right? You really are. Anyway, but red line maps, there are red line maps that exist for communities across the Commonwealth, not just Philadelphia, but places like Erie, places like Altoona. I'm sure you guys get patients from Erie and Altoona, right? And of course, here in Pittsburgh. So let's take a closer look at Pittsburgh. And in fact, I want you to understand why the federal government deemed some communities worthy for federal investment, worthy for municipal investment, and why they deemed other communities not worthy, okay? Now, again, this is the 1930s, but I have a feeling as we listen to some of the descriptions, you will see echoes of what's happening in today's society, all right? Okay, so here is Aspinwall and Fox Chapel. This is still a pretty nice neighborhood today, right? This area. Okay, because I looked this up. I did a little research for y'all. All right, this is what the federal government surveyors said about this community. The area is aristocratic. We wouldn't use that word today, but you know that was a good word for them back then. Pride of ownership is very good. Oh, that's nice. These people care about their homes and their lawns. Infiltration of who are the people moving into this neighborhood? They're desirables. Okay, what does that mean? Well, it means that there are no Black folks there. That was one of the reasons given for this neighborhood. I know this is some of y'all's neighborhood, right? Squirrel Hill. Squirrel Hill, one of the best sections of the city limits. Home prices have gone up a little bit since then. But here's an issue. Here is a problem that they noticed, something that threatens the quality of the neighborhood. Beware that the section is threatened with Jewish encroachment from the South. This was considered a problem for that community. Lawrenceville, is that a neighborhood anybody has heard of before? Lawrenceville, where we are, it's considered a good working man's district. Buildings are old, but substantially built. What are the problems? Why was it given a yellow grade? What was the issue there? Foreign born, there's Polish people living there. And that was on par. Poles living in the community was on par with the obsolescence of the properties, okay? And then, of course, the Hill District. What about the Hill District? Well, it happens that this neighborhood is no good for federal investment because there's too many people of Jewish members of the Jewish community living in that neighborhood. And oh, by the way, Black people are starting to move in too. And there's a lot of folks who are foreign born. This community checks two of the boxes for me, and maybe checks a few boxes for folks in this room. These are the reasons the federal government deemed these communities not worthy of investment. And I want to take a moment to mention that I hope you all are familiar with this history. Who in here has heard of the Freedom House ambulance program? Y'all should know about this, right? This is y'all's history here. So it's a real privilege for me to be here and to be able to speak about the great work of Drs. Peter Saffer and Dr. Nancy Carolyn, who really established the field of emergency medical services, EMS, out of a need. The need being the issues getting acutely ill Black folks to emergency rooms that would care for them. Back in the day, you would maybe call up a mortician who would throw you in the back of their vehicle, or if a police officer was nice, they would drive you to the emergency department. There was no formal system of emergency medical care outside of the hospital. And it was really incredible work done here by University of Pittsburgh faculty and committed members of the Hill District community who established the field of emergency medical services that we all rely on as a country today, something you all should be very proud of. All right, well, Dr. Ray, thank you for that history lesson. That was thoughtful of you. I can see you know something about what Pittsburgh was like in the 1930s, but this has nothing to do with us now. After all, didn't you just have dinner down there in one of those red neighborhoods. It looks pretty nice now, wouldn't you say? Well, if we look at the community today, we'll notice that residential segregation today is almost as bad as it was back then. You could literally determine where people live by the streets that divide them. And unsurprisingly, where we see minority communities, we also see a dramatic difference in home values and residential income. I don't have time to go into this very much. This is something you should do, not when you're on service, but maybe when you have some time to kill. Go to the Digital Scholarship Lab and take a look at this. This graph looks at the red line communities on the left and maps them onto the social vulnerability scales on the right. And with the exception of the communities that have been heavily gentrified in our downtown inner core, you'll notice that many of the neighborhoods on the left, which were redlined in the past, remain those communities that are socially disadvantaged today. All right, so what about income? We've just talked about residential segregation. What about income? If we consider that home ownership is the primary mechanism of wealth transfer in the United States, it should be no surprise to anyone that one of the most significant barriers then to minority communities developing wealth is their lack of home ownership, all right? And these things are not disconnected. Several structural barriers prevent wealth building among Black communities in particular, things like wage inequality, higher unemployment, banking and lending discrimination. I'll pick on Wells Fargo for a minute here. Many of you have seen stories in the news. At least 2 or 3 times in the last 20 years, Wells Fargo has been sued for discrimination, frank banking and lending discrimination against communities of color. And so we should be aware that these things are still happening today. Though I think Wells Fargo is headquartered in Philly, right? It's not here. So, well, you know, those people over there, what do they know on the other side of the state? And things like racial disparities in home ownership and lack of intergenerational wealth. What does this result in? It means that the average wealth held by a Black family is 10 cents for every dollar of that you find in a white family in the United States. Really dramatic differences. All right. But how can we know that these social differences are truly examples of racism and not just the sort of things that happen intergenerationally? Indeed, how do we even define racism? This is one of my favorite slides. How many of you know Dr. Kamara Jones? She's remarkable, isn't she? I had the chance to go to dinner with her guys the other day. She came to Columbus and she spent some time with us and I got a selfie. Just gonna throw that out there. Dr. Kamara Jones is a rock star, family physician, a really remarkable woman, and a past president of the American Public Health Association. She has the best functional definition of racism that exists in our world today, period. This is a great opportunity. Those of you who, like me, like to screenshot slides on people's talks, please do so, post it on social media and tag Dr. Jones. She defines racism as a system of structuring opportunity and assigning value based on a social interpretation of how one looks, which is what we call race. And this system does 3 things, folks, 3 things. Number 1, it advantages unfairly some folks. Number 2, it unfairly disadvantages other folks. But the worst thing that it does is that it saps the strength of the whole society through the waste of human resources. I want you to think for a moment about the millions of actors, scientists, engineers, inventors, clinicians, parents, children that our world has been robbed of because of acts of social discrimination based on race. Think about that. Think about all of those contributing Americans that we've lost because of racism in the United States. And I want you to think about how this definition can be extrapolated to other minoritized populations. Just a few examples: women, immigrants, LGBTQ people, unhoused people, indigenous people, people with disabilities, people living in poverty, people living in rural communities. A system of structuring opportunity and assigning value based on people's social interpretation of whether or not they fit in. These things have long-standing consequences. So, how do racism and systemic inequality influence child health today? All right, and how can we recognize it and document it in our scholarship? So, I want to show you just a few papers real quick, examples of how you can critically appraise your own research to understand injustice and how it intersects with the clinical care that we provide our patients. I'm going to use examples from pediatric nephrology. I know Dr. Moritz would agree. I'm doing so because it is the single best field of medicine that exists today, obviously. However, I do hope that you will apply what we're learning through our discussion of pediatric nephrology to lesser fields of pediatrics, okay? The ones that the rest of you are a part of. All right, so one of the most common examples of the use of race in medicine is the presence of the so-called race modifier in adult estimating equations for glomerular filtration rate. And I'm seeing you glaze over in fear of your medical school renal physiology course. I promise this will be painless, all right, y'all? I promise. So, in order to avoid expensive and invasive methods for measuring kidney function, estimating equations have been developed to approximate kidney function, mostly based on what famous serum biomarker? Creatinine. Yeah, say it with your chest. Say it with pride. Yes, creatinine. That's exactly right, based on creatinine. And it turns out that creatinine, a protein which is found in blood, and it varies with body composition and muscle mass, that these are anthropometric matrices that have been fraught with racial bias for years, okay? Muscle mass, body composition, et cetera, et cetera. So for years, two of the most popular equations for estimating kidney function in adults used a so-called race modifier to account for a very true, statistically significant difference in GFR when the study populations used to derive these equations were divided into two groups, Black and non-Black, okay? But if we all agree that race is a social construct, which it is, right? Because my race here in America changes if I go to another country where people's ideas about race are different. If we agree then that race is a social construct and it has no biological basis, then how can we draw biological conclusions to the use of race in these equations? For example, how was race measured in those studies? I can tell you, in some of the cases, the study staff just said, yeah, I think you're white. I think you're Black, okay? It's very fascinating. You know, I remember, I won't tell you where this happened, but if you're smart, you can figure it out. I was having a discussion with an attending in a faculty meeting, and when one of the attendings said, I just don't understand. My patient is ApoL1 positive, but I don't understand because they're white. You guys have heard of ApoL1? ApoL1 is a risk gene that is associated with sub-Saharan African ancestry that confers an increased risk for chronic kidney disease, mostly in adulthood, okay? So this attending was super confused, like, I don't get it. How is this risk gene that's positive for people who are of sub-Saharan African descent present in this white person? And I had to explain that when two people love each other very much, sometimes one of those people way back in their history, maybe further back than your eyes can perceive, happen to have sub-Saharan ancestry, sub-Saharan African ancestry. And so these are all weird rules that we apply in society. We can't make these rules clean when we apply them in real life. And the problem with the use of race in these equations was that they unfortunately did some pretty bad things when it comes to risk profile, especially for Black Americans in this country who are at increased risk for kidney disease. It turns out that we were overestimating their kidney function, and there were some bad consequences to that. Worse drug dosing, for example, of certain medications that were nephrotoxic, longer transplant wait times, longer referral time for chronic kidney disease, and longer time before starting dialysis. So the question has then to be asked, how does the potential for delayed diagnosis, even if just by a few months, exacerbate disparities that exist within the diagnosis and management of kidney disease? Well, here's a few examples based on some of those structural inequalities that we talked about before. From a food perspective, decreased access to nutritious food could accelerate progressive kidney disease. That's a problem if we're diagnosing patients later than we should. Disproportionate representation of low-wage jobs and underinsured status means that these populations are already at high risk for decreased access to care. What about health literacy? Poor health literacy and an inability to navigate the healthcare system effectively means that these patients will often rather present later in their disease course than they should. Increased stress and allostatic load contribute to renovascular disease risk. And we know that in many of the communities where our minority folks live, that those communities have a much higher incidence of police contact. And of course, delayed referral for chronic kidney disease, dialysis, and transplant care means longer transplant wait times and increased dialysis morbidity. All of those things are no bueno for nephrologists. That's why in 2020, a consensus task force of the American Society of Nephrology and the National Kidney Foundation, by the way, spurred to action by medical students across the country who recognized this and really brought it into the consciousness of our field. This task force was convened to evaluate the practice of using race as a modifier in these equations, and then in 2021 published their findings suggesting that this practice should be discontinued. They concluded that new EGFR equations that incorporate creatinine and cystatin C, which is the new kid on the block, my favorite new biomarker, but they omit race, that these equations were more accurate and led to smaller differences between Black participants and non-Black participants than the equations without race and with either creatinine or cystatin C alone. More than just acknowledging that we could use a different equation, it was important to show that the equation performed better at estimating accurately a patient's kidney function regardless of their race. And this really was a turning point for our field. Another study, this is a good one. This was published by my very, very good friend, Dr. Michelle Starr. She's faculty at Indiana University, but she did this actually while she was a fellow at Seattle Children's. She found that while food insecurity is present in about 20% of American households, by the way, let's push pause there. 1 in every 5 people you meet doesn't know where their next meal is coming from in the richest country in the world. I hope you recognize that as a problem, regardless of whether you're in general pediatrics or you're a nephrologist like me. I tell folks all the time, they ask me why I'm so involved in advocacy work. You're a pediatric nephrologist. Isn't advocacy for general pediatricians? I tell them, if you are concerned about food insecurity in a general pediatric population, you had better believe I am at least as concerned as you as a pediatric nephrologist, where my patients' dietary restrictions are often significantly more burdensome than those in the general population. Anyway, I'll step off of my soapbox and back onto this podium. While 20% of US households are food insecure, she found that in their in-center hemodialysis unit, 60% were food insecure. And by the way, I would hazard a guess, while she was courageous in using the data of her center to publish this, we would probably find very similar data here in Pittsburgh and very similar data in Columbus, where I practice. And oh, by the way, it was associated with higher healthcare utilization, not good, increased infection rates, not good, and lower health-related quality of life, also not good. So let's step back and consider how structural inequalities might interface with food insecurity, and considering, for example, that housing status can impact your dialysis options, and housing insecurity is a major risk factor for food insecurity. Obviously, we just mentioned that nutrition and chronic kidney disease are closely linked. And oh, by the way, if you're undernourished, you're even less likely to get a transplant, which will increase your time on dialysis. The ability to purchase nutritious food isn't so easy for everyone. And caregivers who work multiple low-wage jobs are often unavailable to assist with care. Residential segregation, as we've talked about, and the historical legacy of redlining often correlates with food deserts. And over-policed neighborhoods are less desirable for investment, less likely to attract supermarkets and fresh food vendors as well. And increased healthcare utilization in the context of end-stage kidney disease is a burden to the subsidized safety net programs that many of our patients and families rely on. Another quick study, observational study of children with mild to moderate chronic kidney disease, looked at neighborhood level poverty and disadvantage. Y'all, this is stuff you could do. Looking at data in your, as I said, lesser fields of pediatrics. I want you to consider how this might relate. They found increased odds of hospitalization and increased odds of emergency department use. We've talked about economic inequality, depriving many of these communities with the ability to build and transfer wealth, to weather health crises. We've talked about the legacy of redlining that exerts insurmountable downward pressure on the economic viability of many of these neighborhoods. One thing that we haven't mentioned yet is the environment. Y'all, we're living through the greatest climate crisis that our planet has ever seen, and communities with high neighborhood deprivation scores are much more likely to have unclean air, unclean water, and unclean soil, okay? All of which bad news for children with chronic kidney disease. One of the things that really frustrates me about talks about health disparities is that often we'll do what I've just done and list all of the terrible things that happen to Black and brown people or poor people or rural people or immigrant people, whatever, as if there's nothing we can do about it, as if we're powerless to affect change. I'm here to tell you that that is not the case. And this study is exemplary of that, okay? Another very good friend of mine, y'all, I have some smart friends. I hope y'all know that. I got some real smart friends. Another really great friend of mine, Dr. Jill Chrisberg, who is faculty now at Lurie Children's in Chicago. It's interesting, all my smart friends are in the Midwest, but that's, I don't know. But she's at Lurie Children's in Chicago, but did this work while she was at Stanford. She looked at the changes in racial disparities in pediatric kidney transplantation after the implementation of a new kidney allocation system. So in 2014, a new organ allocation system was implemented nationwide in an effort to provide more equitable access to kidney transplants. And specifically, this new system featured a change in which a patient's time on dialysis prior to being listed for transplant was counted towards them in the point system for them to go up on the waiting list for kidney transplantation. And what did we find? Dr. Chrisberg found, and her team found, that there were some very good changes that actually attenuated the disparity in kidney transplant access, specifically time on dialysis to kidney transplant. What does this mean? This means that there was less inequity in the metrics of time on dialysis to transplant and odds of short-term graft loss after this change was implemented. We actually eliminated the disparity in kids by race, in kids having access to transplant by just making that one change. Once they are placed on the list, their time on dialysis to kidney transplant is similar to their peers of other racial backgrounds. This work demonstrates that systems level changes can be engineered that help us to address racial disparities. We should all feel empowered by this kind of work, okay? So what can we do to mitigate disparities in the work that we do? Nephrologists and even other pediatricians can advocate for safe and affordable housing for all children, especially those living with CKD. We can improve access to and education regarding healthy and nutritious kidney-friendly foods. We can support institutional and, yes, societal policies that limit the influence of income on access to excellent kidney care. We can improve patient education and health literacy that can address adherence and psychosocial barriers. And we can certainly advocate for safe and healthy environments for children and families to live in that optimize their kidney health. So hold on a second. Dr. Ray, you on the one hand are telling me that race is a social construct with no biological basis, okay? But on the other hand, you're showing me all this data that seems to link real world biological outcomes to people's race. What gives? It's real simple. Race is real, but as a social construct, its inconsistent and biased use in drawing biological conclusions is incredibly fraught. So we should be very, very careful how and when we use race. By the way, like all other population level risk factors for disease, we should not attribute a population level risk factor blanketly to every individual patient that we see. None of us would do that in our daily practice, right? We shouldn't do that in our research and scholarly work as well. So as careful pediatricians and researchers who seek to do no harm, we need to understand the context in which we are talking about race or any of the other social constructs and inequities that we find, and be careful the conclusions we draw. Because after all, when we measure the impact of race on clinical outcomes, very often what we're measuring is the impact of racism on those outcomes. And I'd like to take a moment to just, point out that we're smart. We understand that social factors influence the health of our patients. As much as 80% of our patients' health outcomes have nothing to do with us. I'm sorry to burst your bubble. I know you think you're good, but you ain't that good. You know what I mean? As much as 80% is related to things like socioeconomic factors, the physical environment in which our patients live, and their health behaviors, right? So consider the things that can negatively impact that, like systems of inequality that inhibit the attainment of wealth and opportunity, or chronic underinvestment and shady real estate practices that cause displacement, or unhealthy behaviors which are actively promoted and marketed to vulnerable communities that contribute to weathering and despair, and things like medical distrust and underinsured status that results in problems as well. Just while we're on the topic of medical distrust, this has been we've heard about this a little bit, right? Medical distrust in the Black community. And I know you thought that when I was going to talk about medical distrust, I was going to talk about the Tuskegee experiment. And I know everybody in here knows about it. We've all done city training, right? So we know about the Tuskegee syphilis study. But that's not the reason why patients don't trust us. I think we need to recall that there are more contemporary examples of injustice that our patients are familiar with. Take, for instance, the Black maternal mortality crisis that nearly claimed the life of tennis icon and greatest of all time, Serena Williams, when she was delivering her first child, Olympia. She talks about having to demand a CT scan for a blood clot that her clinical team initially denied her, thinking there was no indication. What does she know about a blood clot? Well, it happens she knows a lot. She's an elite athlete who is taught what to know about her body. And oh, by the way, she has a sister. I don't know if any of you have heard of her sister, Venus Williams, who, in addition to being one of the greatest tennis players of all time herself, happens to have an autoimmune condition, Sjogren's disease, that predisposes her to blood clots, something she and her sister have probably navigated together. And of course, the story of the late Dr. Shalon Irving, who was a member of the Uniformed Public Service Corps and a Hopkins-trained epidemiologist who passed away following the birth of her child after making multiple visits with complaints to her healthcare providers. Communities, marginalized communities, have stories like this that aren't covered in the nightly news, stories that exist in their homes and their families that also influence whether or not they trust you. There are things like myths and conspiracy theories. I saw this one morning on my Instagram. Yeah, you know, you scroll through Instagram in the morning. You know, I'm just like you. This is what I saw. Black people, get that organ donor blank off your ID. Who knows why this was said? Somebody shout it out. What's the implication here? That's right. You're not going to get good care, and they're coming for your organs, right? Because Black people have strong organs. We want them for organ donation to rich white folks, and so they're not going to save your life if you come into the emergency department and you're an organ donor. Now, you all will have to tell me where in the ABCs we learned about checking people's driver's licenses for their organ donor status, right? Of course, we don't do that. None of us do that. We go into all of our patients' acute health crises trying to save their life. But the community doesn't know that. And these rumors permeate and influence whether or not they trust us. Really quickly, a great quote from my friend, Dr. Derek Paul, who says, when clinical medicine can't do any more to help your patient, but society can, social advocacy becomes the standard of care. And I love this quote. Many of you may know Dr. Kimberly Manning. She's social media famous, one of the great medical humanists and professors of medicine at Emory University. She signed up to do one of the COVID-19 vaccine trials specifically so that she could encourage her patients at Grady Memorial Hospital in Atlanta to be comfortable with the vaccine. She talked about that experience in The Lancet. And I love this quote: acknowledging every aspect of the barriers for Black Americans to enrollment in clinical trials is critical to moving forward. We are not simply untrusting, we remember. So the next time you're interacting with a patient who is concerned or has some mistrust of you or the healthcare system, instead of wondering what's wrong with them, I want you to think what has happened to them that might have caused them not to trust you, and what will it take to rebuild their trust. All right, so I only have a couple more moments remaining, so let's do this. How can we build durable and trusting relationships as a path to move forward in kidney health equity? Well, one of the things that we can do is acknowledge with our minoritized colleagues and patients the racism and otherism that we see in the world today. You know, we've talked about racism, but certainly there are some other issues going on in our society today. There is a movement of otherization in our world, a current, an undercurrent to separate and divide us, and we must push back against that. We push back by helping our colleagues and patients and families who are different from us to feel seen, valued, and heard. We've got to champion workforce diversity and inclusion through intentional recruitment, mentorship, and partnership. This goes beyond just pretty pictures, right? Like we find the handful of folks with a little bit more melanin, or folks that look a little different, or they wear religiously affiliated clothing, and we make sure to feature them on our brochures. You know, I've been on a couple brochures, y'all. I know how this goes. I know how this works. And we say, oh yeah, you know, this is diversity. Well, yes, that is an aspect of diversity, but who is at the table of your hospital senior leadership team? Who is at the table of your committees, decision-making bodies? Who is on your panels or manels? Shouldn't be having any more of those at your conferences. Let's make sure that we're putting it into practice. I'm proud that we as a field in pediatrics acknowledge the impact of racism on child and adolescent health. And I'm proud to have done some work at Nationwide Children's to help increase the diversity in our programs through a variety of really hard-hitting efforts. and we've done better. And everyone can do better in recruiting and diversifying our teams. We should be screening for social determinants of health in clinical encounters and engaging with new voices. This is one of the reasons I love Twitter, and I don't call it X, it's Twitter, okay? Everybody knows it's Twitter. I love being on social media because it allows me to engage with folks who are different from me and an opportunity to expand my professional network. And we need to be thinking also about explicit and implicit bias training as well. How many of you have heard of a PAMSA? Anybody here heard of a PAMSA? The Asian Pacific American Medical Student Association. This is one of the most special invitations I've ever received. I had the opportunity in 2022 to speak at as the keynote speaker at their annual meeting, which happened to be held in Columbus. It was the first time that I, as a minority, found myself in a room full of people of another minority group. It was a really different situation. I'm used to being the only Black person in a room full of white folks. That's one thing. But to be a minority invited to speak about my minoritized experience in a room full of people of a different minoritized group was really very special to me and helped me to appreciate the experiences that many of my white colleagues might feel when they are in spaces that are non-white, predominantly non-white. It gave me a lot of empathy for the experiences of my Asian and Pacific American colleagues and medical students and trainees. It was a life-changing experience for me. I hope each of you has the opportunity to experience something like that, to expand your horizons as well. We've got to listen to others. We need to resist the urge to colonize the communities in which we work. What do I mean by that? I mean that a community should not be underserved if you are there serving it. Because if the community is underserved and you're there working, well, there's a problem. There's a problem with your service. We should be doing better. And we should understand that our communities deserve nothing about them without them. They should be able to lead what happens in their communities. Finally, we need to practice what we preach with patience and partnership. It means that we need action and accountability. Okay, so if we want folks to do meaningful work in diversity, equity, and inclusion, we don't just need to talk about them or talk about the work and give them fancy titles. We need to make sure that they have FTEs to support the work that they're doing. We need to make sure that we are encouraging Grand Round speakers to include a slide or two when they're talking about their research on the implications of that work in minoritized communities. And we need to encourage residents and trainees who are interested in basic and translational science to think about how that work impacts communities that are different from their own. That's very important. Avoid an over-reliance on minoritized team members to do the work of reaching out to minoritized groups. Learn to do the work yourself, and take risks and be transparent in your communication and engagement with those populations. So I have a lot of hope this morning. You know, we were compelled several years ago to take a stand against racism and a stand for health equity and a stand for justice in society. I hope we are still committed to those principles, principles of standing against racism and anti-Semitism and Islamophobia and homophobia and transphobia, standing for communities that are marginalized, poor folks, rural folks, indigenous folks, new Americans and immigrants. I hope we are motivated to care for those who are different from ourselves. And I certainly have faith in us to do that work together. So with that, I want to thank you all for your attention, and I can take a couple questions if we have a moment for that right now. Thank you.